Hello, welcome to this presentation. I'm Stephen Harris from School of Health and Related Research at the University of Sheffield. I'd like to talk to you about how different models of health service delivery might affect patient engagement in their own care. And this really journey from a realist evaluation project that started off looking at small-scale quality improvement projects across a number of sites, but ended up realizing that there were larger, more strategic decisions that needed to be made in terms of service delivery models and making recommendations on how they should be developed and delivered. So it's an overview of the presentation. I'm going to be talking about what the problem is, introducing briefly the intervention, the research design, and then starting to work through looking at how the findings were developed and how the analysis developed. So starting with the initial program logic and theories, the development of context, implementation, mechanism and outcome theories, development of mid-range theories of change that linked in with those, and then onto the designing of archetypal models. Then we've got some key messages for shared care for this project and key messages for realist investigation. So shared haemodialysis care is a treatment for people with end-stage kidney failure. It involves them being dialysed for around 3 to 4 hours, 3 days a week. And this is traditionally a treatment that's performed on patients by nurses, so patients have traditionally had very little involvement in their own care. It's usually carried out in a hospital or a satellite unit, and sometimes carried out by the patient at home, but that's quite rare. Now, there's very good evidence that patient involvement in care, in their own care, is beneficial, but there's not very much of it happening. So the objective of the program was to give people who receive dialysis at centres to have the opportunity to be given choice and information to participate in their treatment and potentially improve their experience and their well-being, quality of life and outcomes. So this is the rundown of the intervention. It was at 12 sites across the UK. It started off with a face-to-face site initiation visit. We had some patient-level audit data looking at the number of tasks patients were carrying out in their own care. The key intervention was a series of learning events that small teams from each of the trusts came along to and often brought a patient with them as well. And this was to teach them quality improvement methodology and how to conduct plan, do, study, act cycles to try and increase involvement of patients in their own care. There were action period calls to review the PDSA cycles, deliver any teaching that needed doing, to link up the sites and to improve that kind of peer-to-peer relationship so that each site could learn from each other. And there's also progress support through site visits, telephone calls, emails, correspondence, and so on. And we had a website as well, which was a repository for materials and information that was put forward by the sites that they thought would be useful for other people to know. The research design, it was mixed methods. We had a stepped wedge cluster randomized controlled trial. There was parallel economic evaluation and realist evaluation. The realist evaluation began with informal discussions. We had a social media campaign to try to develop the initial theories, which I'm presenting in another presentation in this conference, and stakeholder engagement. And then onto the formal data collection through interviews, documentary analysis. We did workshops at learning events with staff and patients, and we made site visits and observations. So the initial program theory, you'll see here on the left-hand side, we have the trusts there with their contexts, the leadership, their budget, the stability of staff, and so on. And it was intended that the staff would come along to the learning events. And some patients as well, and they would learn quality improvement methods. They would network with other sites for peer support, share ideas and materials and so on, and go back to the trust and introduce changes in their trust. These site-specific changes would then have an effect on working practices, opportunities, motivation, etc., leading to increased involvement in care, a wider range of patients involved, more resilience in shared care, leading to long-term outcomes such as shared care being business as usual and having a high profile. You see the smaller arrow there. So the key assumption was that there would be big differences between intervention sites and no intervention sites. And the no intervention sites, we expect some shared care, but very variable and low volume. So this is an example from the text logic model we started putting together. So this is a repository for all of our ideas, thoughts and data as we were developing the theory for the program. So this is the ID for this is 4, the theme is promoting peer support. And so the inputs were patients receiving support from other patients. For instance, always using the same bed and being with the same people next to them and so on, so they could build relationships. They could learn tasks together. We found that competition was quite important for some people. So they would compete to try and carry out more tasks and more complex tasks than other people that they knew at the units. There'd be support, advice, sharing experiences and so on. And then leading to short, medium and long-term outcomes. So this was a text logic model that went through various iterations and, as I said, was a repository for all of our theorizing early on. So from a patient point of view, what works for whom in what circumstances and why? We found that some people were already very highly motivated, people who just wanted to learn, and they thought that, the more that they knew, the better. People who related this to their idea of their personality, for instance, always being inquisitive, wanting to know what's going on. People had different learning styles and preferences. So examples here, one of the sites had a very stop-start approach, which didn't suit various people. Some people preferred on-the-job training. Some people preferred having some homework to learn separately. We found there was quite a few individual anxieties that needed to be recognized and addressed. For instance, in some sites, shared care was actually a route to trying to get patients to dialyze at home. And patients in these sites felt under pressure. And as soon as they started carrying out tasks, they thought they would be pressurized to leave the unit where they were quite happy having their care and be pushed to go home. So quite often there was reassurance around that. And reassurance about being scared, about taking part in their own care. And different levels of perceived and actual self-efficacy. So people thought that they could never do it and didn't trust themselves, preferred to let the nurses do it. And physical barriers as well. So not being able to see their injection site and so on. So here's some of the key themes from staff. Staff retention was very important. So those members of staff who implemented the process for shared care often left the unit if it wasn't embedded culturally within the unit. And we found that shared care was often quite susceptible to dropping off the agenda, and there wasn't much resilience in those situations. Senior support was very important. Other staff's attitudes as well. So when only some of the staff are carrying out shared care, the other staff might have negative opinions about it and negative attitudes, because it's a different type of work. So it's less about doing and more about education and training. Staff shortages, big problem. and perceptions of available time. So this quote, for instance, it's frustrating because I'd much rather be spending time with patients and helping them to do it for themselves, but you don't always have the time to do that. But we did find that ultimately it does save time when patients do shared care, and this was demonstrated from some of the economic evaluation that we did. It's a process of training them that takes the time, so ultimately they did save time, but it was that spending time on training in a high pressure situation, people, a lot of the staff felt as if they just wanted to carry out the work as they would traditionally. So here are the context, implementation, mechanism, outcome theories that we put together. So this one is promoting awareness of shared care. In some units, there was no visible or verbal signs of shared HD. Sometimes the shared care was carried out in separate bays or during separate sessions. Staff didn't discuss share HD, for instance. So the innovation here would be around awareness raising with posters. Some staff wore badges saying, please ask me about shared care. Learning events in the units, other patients visibly doing share HD, leaflets, talking, coffee mornings and so on. But we found that some of these aspects were suited to some people. For instance, the extracurricular coffee mornings only attracted to certain types of people who enjoyed these kind of social interactions and didn't mind having dialysis related activities while not actually dialysing. A lot of people just wanted to be away from the unit. So with this theory, patients became aware and curious and then sought further information, such as asking staff or other patients about shared care. And the outcome was that they get on the road to learning more, and ultimately they're able to make informed decisions and then possibly a higher uptake of shared care. Promoting peer-to-peer interaction was important, and the opportunities for engagement with other patients was an important context here. So as I said before, going to the same bed, having relationships, being close to people who they could communicate with while they were dialysing. Different types of pre-dialysis, so in the waiting room, whether they drift in or whether they are penned into the waiting room, kept in the waiting room altogether, which gave opportunity for social interaction, and shared transport as well was another opportunity for people to get together and provide that peer-to-peer interaction. This gave reassurance, helped people feel more secure, felt that they'd be supported if needed. As I said, there was a competition element and competencies, learning, knowledge, training, advice. And the normalization of shared care as well was important when other people are seen to be carrying it out. And actual physical, emotional, informational support and developing confidence. So these are some of the mechanisms that we're working around providing these outcomes of feeling part of a group, feeling a sense of belonging, physical, emotional well-being, able to make informed decisions, and then again, possibly higher uptake of shared care. We found that there were physical barriers as well as emotional barriers. So, for instance, grip strength, dexterity was an example of a physical barrier. And the intervention here is staff wondering, are there ways of overcoming these physical barriers through support, physical aids, training, clinical interventions, etc. So the mechanism here is staff identifying and being able to address specific physical barriers to increase involvement of more service users with more tasks. And anxiety as well. There was certain emotional barriers around this area. So here it's a case of reassurance, acquired knowledge, understanding and practicing of tasks as well, helped to overcome anxieties, which gave people increased confidence, leading to changed attitudes and intentions, leading to behaviour change. And people felt more in control and able to feel like they're taking control of their illness rather than it controlling them, and possibly improve quality of life and more shared care. There were also experiential and attitudinal barriers. So So we found that some established patients, rather than new patients, any intervention aimed at encouraging them to take part in their own care was often resisted. We found that these people might have ingrained behaviours and attitudes that could be more difficult to change. So almost learned helplessness, old habits. Shared care was seen as being more work, so being nurses' jobs. They felt as if they didn't get paid to do it, and they didn't want to take work away from nurses. So some people were quite protective about the nurses and saying, well, if we did all our own care, the nurses would be out of a job, and we wouldn't like that. So there was lots of these kind of experiential and attitudinal barriers. And with these people, there's a very strict division of roles between patient and clinician. So we started to look at, once we've got all of these context mechanism outcome conjectures together, to try and understand what was happening in what context and how. We started to relate that then to behavior change, mid-range behavior change theories. So this is Prochaska's stages of change, which the interviews were largely around kind of journey mapping interviews. So we were looking at the journey towards shared care. And so the data came out in this kind of format, so that people were reporting they had a period where they weren't aware of shared care, and then becoming aware, they started to contemplate it and prepare for it, take action. And then there was this sort of longer term maintenance of shared care, or potentially relapse due to various reasons. Then as well, another colleague, we were at another conference presenting this, and another colleague presented this ADCARS model of change. And we began to realize that we'd missed some elements, some important elements out from the patient data, and particularly the desire to engage with change, so the kind of motivational element. So we built this bespoke stages of change model for shared care. So we realized that awareness was very much required. We found that people's motivation fluctuates, and this can often be to do with anxieties as they develop competencies and the knowledge and find out more. So quite often reassurance is required to maintain motivation. Then move to a period of knowledge, improving knowledge and understanding. So just being aware of what is involved, what's possible, and what they might be capable of doing. And then moving on to development of skills, competence and confidence. And the knowledge and understanding can have a link back to anxieties and also back to motivation. So this is a bit of a circular effect going on there. And the final endpoint here is shared care, which requires reinforcement, adjustment, support, rehabilitation and maintenance. And there's always the potential that that patients will slip back down for various reasons and do less of their own care at any point. So we started to develop these models from what we knew about the context of the site and the service delivery, and what the patients and staff were telling us about the way that services were delivered. So we had these staff models where somewhere staff involvement was high. It had a high impact and high resilience. But then we had these other staff involvement models with low impact and low resilience. All around this kind of changing the culture and the service. Some were more effective and some were less effective. And outcomes were as well mediated by patient involvement models. So we had these service models, some that encouraged high uptake and some that encouraged low uptake around the opportunities for patients. And creating these outcome patterns that broadly fall into these sustainable change and maximum patient involvement, or on the other hand, temporary change and minimum patient involvement. So these are what the models look like. First of all, we have the lone champion, which was an individual just struggling to do as much shared care as they could. A shared care leader that was trying to bring everyone on board, small segregated teams, We had distributed teams, so some nurses supporting shared care throughout the whole unit. We had some units where all nurses were involved to some extent, and it was spread throughout the culture, but not with very high commitment necessarily. Then we have this sixth one where all nurses were committed to supporting shared care. And then the next model where all staff, so at all levels, from porters, healthcare assistants, management up to senior level, and so on, all committed to supporting shared care. And then finally, it's co-production model where all staff are committed to supporting shared care, with patients very much engaged in the service design. Of course, service user involvement in design and delivery is desirable in all models, but that kind of represented the ultimate co-production model. In terms of patient involvement, we found these archetypes of service delivery. So we have number one, all or nothing. So this is patients dialysing independently, or no involvement at all, with a small amount of training and a small amount of self-care. Some sites it was a route to home dialysis only, so home hemodialysis. Some self-care while people are waiting to go home, and some training there to achieve that, and quite a lot of patients with no involvement. Again, number three, quite a lot of patients with no involvement. And here we've got segregated care, so shared care is happening in separate bays. And there's not good visibility across the unit that this is actually going on. There's a transient model where shared care was on the unit, whereas training was in separate bays. So patients were chosen, they were taken to train in separate bays and then put back on the unit to carry out their own care, or elements of their own care. And then more integrated model. So here, people who weren't involved were the ones who weren't selected. And patients were selected for shared care on the unit, and the training was on the unit. So everything was all integrated in the same place, which is, again, would help to increase awareness. This business as usual model, where most patients were facilitated to be as involved as they wanted, and training and support was part of the culture performed by all on an ongoing basis. But some patients still had no involvement due to practical or cognitive issues and so on. And then this more rehab approach. So we saw this not as a fully developed model, but through some of the activities of some of the staff that we talked to, where most patients would be facilitated to be as involved as they wanted. Training is part of the culture performed by all on an ongoing basis. And there's a range of approaches to give opportunity for involvement, for instance, through translators, vision aids, etc. And the only people with no involvement there are due to rehab issues, potentially. So in summary, the key elements for successful implementation is make shared care everybody's business. So we witnessed the lone champion and shared care leader models fail and small teams struggle. However, we now understand that these are very tenuous models with low resilience. Integrate shared care. So segregated shared care limits patient engagement, but was often considered easy to manage, at least initially. We found it's important to have a roadmap, so a strategic sense of progression is very important to sustain or scale up shared care. And the expectation to develop. So members of staff at each site have different approaches and strategies to increase shared care, but it wasn't set within a framework of progression to more stable or scaled up models. Once units had a model, they tended to stick with it. So if they were doing shared care in bays, they just, when that was full, they just say, okay, so we need to build a new shared care bay, instead of thinking about different, more radical ways of delivering services. And understand the patient's experience and being mindful of the stages of change and being prepared to support the patient during setbacks. So some of the reasons for varying outcomes in different contexts. So spontaneous shared care. So some patients we found tended to want to be more involved in the care with little or no encouragement or support. So these are very self-starters and had a lot of perceived self-efficacy. Visibility was very important. So awareness we saw as a first main step towards shared care. And this was influenced by lots of elements, including separate bays, staff discussing shared care, and posters and so on to raise awareness. Starting early, so it was much more difficult to introduce shared care as a change to treatment rather than introducing it as the treatment when the patient begins dialysis or even pre-dialysis. So they can be introduced to this when it looks likely that they're going to go on to dialysis at some point. So understanding the individual is important, their motivation, their perceived and actual efficacy, their anxieties and learning styles. Don't rely on a small number of people to maintain shared care. So we found that not to be a very resilient model. It was important to change the culture through recruitment, induction and training. So having your staff know from the start that this is part of their role, and co-production with patients can keep shared care as a priority. Collaboration at all levels as well is really important to establish commitment throughout the organisation. And maintaining shared care can require support and rehabilitation. High levels of engagement we found declined over time, so individuals will have setbacks. So I suppose the main lessons for realist inquiry. So this project started with a focus on small-scale quality improvement projects and how they were working and evaluating them. At the end, though, we found that it was the models of service delivery, particularly around staff engagement and patient involvement, that was preventing the interventions being effective. So the end focus was more on strategic recommendations for those two key aspects of service design, the staff and patient involvement. Through the development of the theory, we found that individual patient stories of change and resistance to change helped us to identify the mechanisms and the individual contextual variations, such as people's personalities and character traits that may influence their relationship with shared care. An in-depth understanding of the sites through observations and documentary analysis and in-depth interviews and doing workshops with the teams helped us to understand the sites and to recognize how these different service delivery models impacted on the firing of these mechanisms that the patients were telling us about. So I think we find that there's a recognition that quality improvement will always have a limited impact if staff involvement is small scale and tenuous, and if patient involvement is not inclusive. So now we have recommendations to create a supportive environment where quality improvement projects can thrive alongside the larger culture change, rather than struggling in these more hostile environments that they were trying to work in previously. So services can now look at the range of models. They can recognize their type of service within those archetypal models and choose strategically to move towards a more effective service delivery model that's going to give them better opportunity and better outcomes, and it'll be more effective eventually in the number of people who are carrying out a larger number of tasks. So thanks very much for listening. I can be contacted here if you've got any questions at the University of Sheffield. Here's a note to our funders, the Health Foundation, collaborators, Sheffield Teaching Hospitals, and the project was supported by Kidney Research UK and adopted by the NIHR Clerk for Yorkshire and Humber. Thanks very much for listening, and goodbye.